everyone. Acute pulmonary embolism is no longer a condition we simply anticoagulate and monitor. The interventional toolkit has expanded dramatically, and with it, the complexity of the decisions we face. What do we treat invasively, when, and with what? Welcome to session 2.8, Evolving Treatment Strategies for Acute Pulmonary Embolism. I am joined by an exceptional and extraordinary panel, Dr. Nicolas van Mieghem from Rotterdam, the Netherlands, Dr. Aleksander Araszkiewicz from Poznan, Poland, Dr. Amir Kaki from Detroit, US, and Dr. Sahil Parikh from New York, United States. Welcome, everyone. Hi, nice to have you. We have three amazing presentations, and there's been just so much excitement in this field, especially right after the American College of Cardiology with one of the most important clinical trials that I think was presented. But very important, these presentations will take us from the foundations of risk stratification through the sharpest debates in the field today. We begin with Aleksander, who will set the clinical framework. Aleksander, please present risk stratification of acute pulmonary embolism and guideline-directed therapies.
Thank you very much, Roxana. Good afternoon and good evening. I'm gonna talk during this presentation about the risk stratification of patients with pulmonary embolism and also about qualification to the different therapies, including invasive, of course, treatment. And according to ESC guidelines, we have high risk and non-high risk pulmonary embolism. This non-high risk is our patients with low risk. These are patients with no right ventricular strain, no positive markers, cardiac biomarkers, and the mortality is quite low. Then we have intermediate group patients, which are intermediate low-risk patients with one of, if they have one of two conditions. The one is right ventricular strain in CTPA or echocardiography, or elevated cardiac biomarkers. Intermediate high-risk group, this is the most complicated group, in my opinion. These are patients who are still normotensive. They have no shock, but they have right ventricular strain and elevated markers like troponin or anti-proBNP, and high-risk patients or massive PE patients are patients with hypotensions requiring vasopressors, and these are also patients with cardiac arrest or patients with refractory shock, and these patients are called catastrophic PE patients. So, of course, pulmonary embolism is a disease with many phases, diverse clinical presentations, and the different early prognosis, as you can see here, because in high-risk patient, mortality is up to 50%. And of course, we have the treatment dependent on these risk stratifications, and we have, of course, different possibilities, different therapeutical options, including interventional and surgical therapies. Of course, this reperfusion treatment is for patients with this most severe forms of pulmonary embolism. And as you can see here in the current European guidelines, which are actually a little bit outdated, and we are expecting the new European guidelines in 2027. The basic treatment of PE is, of course, anticoagulation, and if we have high risk, always we treat with reperfusion treatment. Intermediate high risk patients should be monitored and careful and be careful and look at the deterioration of patient. And of course, in other forms, we should anticoagulate and hospitalize this patient, or even we can discharge this patient home and treat it at home. But of course, if we have reperfusion treatment indicated, the first step is systemic lysis. However, if we have contraindications to thrombolytic treatment, which is quite often, or this treatment fail, we should treat this patient with embolectomy or catheter-directed treatment. In intermediate high risk, according to these guidelines, we should wait for patient when patient are deteriorated, and then we should treat this patient with systemic lysis or surgically or with interventions. So of course there are a lot of controversies and gaps in these guidelines, because we know from interventional registries that more or less 30% of patients with intermediate high risk are the patient in so-called normotensive shock, meaning that these patients are still normotensive. That means that systolic blood pressure is up to 90 mercury millimeter, but they are unfortunately with a decreased cardiac index. To address these gaps, there is a second document of EAPCI showing us that some patients not patients with deterioration, because if patients are deteriorated, the mortality is up to 50%, but patients with treatment failure with lack of improvement should also be the candidates for interventional treatment, more aggressive treatment. And of course, how to find this group of patients? We have some clinical imaging and laboratory signs of deterioration or severe condition or normotensive shock. We should evaluate heart rate, RV-LV ratio in echocardiography or CTPA, NT-proBNP, lactates, and all these so-called red flags should be bear in mind when we evaluate the patient condition and qualify the patient to more aggressive therapy, reperfusion therapy, including intervention catheter based therapies. And here in this European Society of Vascular Medicine guidelines published in 2025, we have this red flag similar to these from this statement paper, that we should treat if we have patient with intermediate high risk with these red flags. Of course, we should treat this patient. We should consider to treat this patient with interventions. And of course, there is actually this stratification is the continuous from cardiogenic, from let's say intermediate high risk normotensive shock to the catastrophic P. This is continuous line, and I think that SKY shock classification pyramid is much more useful in the evaluation of this patient than classical stratification according to ESC. And also we have these clinical categories in the novel ACC AHA guidelines, American guidelines, showing us the new categories of risk. These are categories of risk from A to E, and we have new categories D1 and D2. For the first time, we have described this normotensive shock and transient hypotension as possible targets for our interventions, but with the level to be. Unfortunately, I think that after these new trials, Hypato, Peerless 2 trials, Storm-P, this will probably change. And of course, I'd like to finish my presentation with this clinical case of a 58-year-old male with obesity, hypertension with edema of the left lower limb, dyspnea, and he presented with positive troponin, NT-proBNP, highly elevated, and lactate which level which was also increased, RV-LV ratio as high as 1.8, and decreased TAPSI. And of course, this patient did suspected normotensive shock. He was initially treated with a low molecular wedge heparin, but without improvement. And this patient was transferred to our university hospital after consultation with our pulmonary embolism response team, which is, of course, multidisciplinary team, very important for the diagnosis of these patients. In CPES score, he had 5 points, meaning that this patient is at risk of deterioration, and we decided to treat this patient, of course, with intervention. Here our cardiac index was 1.9, showing that this patient was really in a normotensive shock. We performed this intervention with flow trigger catheter. It was, of course, successful, and we had very good hemodynamic effect. Here is flow saver to save the blood, and very good hemodynamic effect. And of course, after that, this patient was discharged home very early. So the current European guidelines continue to recommend catheter-directed therapies primarily for high-risk acute pulmonary embolism in patients with contraindication to systemic thrombolysis after its failure. But we should remember that 30% of intermediate high-risk patients may be at substantial risk of early hemodynamic decompensation called normotensive shock. So identifying these patients is very important and maybe, of course, complicated. And we are observing the real revolution in the stratification of patients with pulmonary embolism, and of course interventional treatments of these patients. So all our efforts are towards the better stratification and better qualification of patients to interventional treatment. Thank you very much.
Thank you very much for that fantastic talk that has generated several questions here. So I'll start this. I don't think maybe some of it will get answered with the subsequent talks, but I thought it was really important to talk about this risk stratification. And one question from the audience is about how you stratify acute PE in the clinical practice. Which scoring system do you find the most effective? Which biomarkers do you rely on, and where do they fall short? And we can ask this from everyone, I think, on the panel. I think there's a lot of expertise here. So let's start with you, Alex.
Oh, okay. So in our hospital, our PERT, we are evaluating the patients using some clinical scores like CPES score, but generally we are observing a few important, in our opinion, signs. The first is, of course, tachycardia more than 100. If we have persistent tachycardia, which is refractory for fluids, that means that this patient is really sick. The second is, of course, respirations. If we have more than 20, 25 respiration per minute. That means that this patient have real severe dyspnea and needs more than 6 liters of oxygen per minute. The next important things are in CTPA. We are observing RV strain. For us is very important RV-LV ratio more than 1 or even more than 1.5. If the patient have more than 1.5 RV-LV ratio, that means that this patient is very sick, and we need this patient. We have to treat this patient very urgent, and even this is for
So
us.
it sounds like to me that you're using a lot of. It seems to me like you're using a lot of your clinical judgment rather than a specific score. Is that the same for the rest of you? Because I want to go on to another question and I want to then move on because we have such limited time. But Sahil, what do you do? Just quickly.
I think that our group, we focus very much on organ malperfusion. So lactate is important to us, hypotension, some of the other clinical parameters. There's a variety of scoring systems, PESI, CPES. Then we really do follow the patients. If they're not initially critical, we have these new paradigms such as the news score, where you can follow vital signs over time and see if there's a delta or deterioration, and that may be a tip off that they need a clinical intervention.
Great. And are there devices that you would go, or should we wait for the talks before we go into the devices? Is there one better than the other? Maybe Amir, you can probably tackle that in just a moment, right? And also with regard to the question on intermediate risk, and how the landscape has now changed with high pytho. I think we're going to hear that in the talks. But more importantly, I think is the very important role of the PERT team. I think that to me is one of the most important areas, and it hasn't been developed everywhere. So what are we doing to actually get that going? Or is this going to be yet another STEMI call being on a PERT call? So who wants to take that? Nicolas?
Well, Roxana, I think we're all evolving in that direction, but I'm a little bit frustrated with the difference in pace of this change in practice. I have the impression that in the United States, this change has already matured much more than the reality, for instance, in the Netherlands, where people keep sticking to outdated guidelines. And I do believe that is the right way to go, to be more aggressive and more interacting with patients who are normotensive but clearly have signs of organ dysfunction.
But when you see a massive clot like that, and of course with like someone who's sort of tenuous with normotensive pre-shock, I just feel like if I'm on the table, I want you to go after the clot and take it out, and then follow it up with some anticoagulation. But let's hear more. So thank you so much. That framework was fantastic. I think now we're going to go to Amir, who's going to map out the landscape of the technologies. Lots of questions on that. So you could already see them. So, hopefully your talk will answer all of them. So please, overview of the pulmonary thrombectomy technologies by Dr. Kaki.
Thank you. Thank you for the opportunity, Nick, for allowing me to be a part of this. My topic I was tasked with was overview of pulmonary thrombectomy technologies. And I'll be honest with you, I've used 4 out of the 5 that we're going to discuss briefly. Just a little clinical context. This slide is redundant, and I think we'll be seeing a lot more of this as this was recently published with new guidelines as how we qualify and classify PE. I think this is very useful. Obviously, I think it was intended to overlap with our SCI classifications for cardiogenic shock, but this is actually very practical. And now that we could talk, when we're talking, we could compare apples with apples. Now, if you look at because we have such a brief amount of time, I'm going to talk about the thrombectomy devices that are commercially available, and we'll go through each of them very quickly and tell you what I think the advantages, disadvantages, and their role in the current PE landscape. I have my own biases. I have the most experience with this technology. This is the Inari FlowTriever. This is a 16. It comes in a 16 and a 24 French iteration. And this is the largest large bore mechanical thrombectomy available. It does have some robust clinical data, registry data, be it in the FLAIR trial, as well as FLAIR 2, which was a real world registry confirming hemodynamic improvement at the time of thrombectomy. Just briefly, this is just a large syringe. It's a suction device. The device is 24 French, as mentioned, but it's very versatile and can get you to the pulmonary arteries without difficulty. It navigates the right heart without difficulties. And you can see here, the clot is taken out. It does have an accessory that you can add on to it to save blood, to filter the clot, and you can return the blood. That is called the flow saver. And we use that selectively based on the patient's hemoglobin and the need to salvage blood. The FlowTriever, the advantages, it has the largest aspiration lumen. It's has some proven clinical data, mostly in the registry, and it allows blood to be returned, as we talked about with that accessory called the flow saver. This is the ideal device, in my opinion, if you have large proximal pulmonary artery thrombus, so saddle, submassive, massive, when you have main pulmonary involvement. The limitations, it is the largest large bore venous device. I don't think that's a problem for us. It's a venous procedure, but for most people, it's not a problem, but that is something that should be taken into consideration. This is not a device that you would use for segmental, subsegmental, or lobar, and I would argue you may not even have to do thrombectomy on those patients. It does, given the bore size, it is the highest vascular complication risk, but I have observed that that's actually been pretty low. The system is a little bit bulky and does require some expertise, but I think the learning curve is relatively steep. I think most people, particularly interventional cardiologists, could learn it relatively quickly. It is contraindicated in small tortuous pulmonary anatomy, which we rarely see. I think it's best used, like I mentioned, and when you have large thrombus in the proximal saddle, it's the best time. When you have patients who are hemodynamically uncompromised, I think it's a great device. That's usually a signal that they have a lot of proximal thrombus. And it's great when systemic thrombolysis is contraindicated, like the remainder of these devices. This is another very commonly used device, at least here in the United States. This is the Penumbra Indigo. This is a smart device. It's referred to commercially as the Lightning. It comes in several iterations, the Cat 8, 12, and now they have a 16 as well. They do have some registry data with Extract, Storm, PE, and it is smaller profile than the FlowTriever. It's more flexible, and it allows you some more options where you could go a little bit more distal if you were interested in going beyond the main pulmonary arteries. It does also have some smart technology to limit blood loss, and this is very commonly used here in the U.S. Some of the advantages of this, it's pump driven, it's continuous aspiration as opposed to, pulling back with the syringe where we lose suction pressure as we pull back the syringe. Some of the limitations, it's slower and smaller. So if you have really large thrombus, sometimes it's not ideal. And if you have patients who present late who may have organized thrombus, it is also not ideal. It's widely used now for low bar and some people who are chasing segmental PEs and distributions beyond the main pulmonary arteries like to use this. It is very flexible and really precise. And so this is the uptake of this with bilateral PE is also extending here in the US. Symphony, I think this is a very nice device. I got to use it in its initial clinical trial. This is a large bore device, and the way I would describe it is kind of a hybrid between the Penumbra device that we just showed you and the Inari device in the FlowTriever. It has both features. It has continuous suction and aspiration, dual axis, and it fragments the clot. It is a larger bore as well, consistent with what we saw with FlowTriever. Some of the limitations are that there's some risk of distal embolization if fragmentation is incomplete. I haven't seen or observed that. It hasn't been used very much in the States, so we don't have a lot of data with this. There's less data for us to glean at. And it's best used in patients who have large thrombus, particularly in patients who have proximal thrombus. It's a larger device. So that's an interesting device. It's called the Symphony, and this is how it looks. It has a vascular generator and a canister. The profile is 24 French like the FlowTriever, so I think that's not a problem for folks who are used to using the Inari platform. The next device is the Aventis. I admittedly have not used this device. This is a large lumen aspiration catheter. It tracks and it has a low profile design. targeting the lobar vessels. It's low profile, navigates very quickly. Good for some, been described good for soft thrombus, less effective for chronic or organized, and not ideal for large saddle embolism. We think we have better options right now. I have not used it, so I can't really speak to the usability or an ideal situation to use it. The AlphaBac is one that I have used. This is it's a handheld device as opposed to its predecessor, which was required you to cannulate the patient and put them on essentially a circuit like VV ECMO, where it suck the clot, filter it, and return it. This is a larger device. It is steerable. It's really good for large thrombus, particularly. But given the other devices that we have, the uptake for this has not been great. It's been late to market. So what is the clinical framework, which device to use? I think in massive PEs in the saddle, I think the FlowTriever is ideal. In patients who have acute soft thrombus or beyond the saddle, you may want to consider the Indigo or the Aventis. They're smaller bore and can get there safely and much more flexible and easy to track. And the subacute organized thrombus, if you need something a little more powerful, TruVec and AlphaVac would work great. And in distal anatomy, again, and the Indigo and Aventis when you're trying to go distal. In my opinion, I don't know the utility of that, clinical value of that, but people are studying that and doing it. And in large saddle PE, I still think FlowTriever is the ideal device, and Indigo can also be used. So why mechanical thrombectomy? I think we've seen the data. It's a very effective procedure. Systemic thrombolytics, particularly for massive PE patients, is not always ideal and often contraindicated. It also carries the known risks that are catastrophic, such as intracranial hemorrhage and major bleeding for patients who are at risk. It's indicated now, mechanical thrombectomy, on the new classifications for PE for D1 patients, D2 patients, E1 and E2. And our observation that has been also reproduced in clinical trials is you see rapid improvement on the table for the patient's hemodynamics. It does not eliminate your ability to use thrombolytics, catheter-directed thrombolytics if need be. And this is becoming more and more common as the PERT teams are becoming more available. I also just want to mention VA ECMO. VA ECMO is an excellent tool for particularly massive PEs, not to necessarily treat the PE, but as a bridge to thrombectomy. And we're doing that in our institutions for patients who present with massive PE for hemodynamic stabilization of these patients and subsequent thrombectomy with whatever device that you see fit. And here's a recent patient, a 70-year-old patient who came in with a massive PE, found to be hypotensive and a profound shock with rising lactates. Patient had a mixed venous O2 of 15, which is very low, with a very low cardiac index. This patient was stabilized. We placed the patient on VA ECMO and subsequently did VA ECMO assisted thrombectomy, and the patient did very well. So the role of ECMO is here to stay for these patients. And it looks like they stopped our slides. But anyways, this was the last slide here. If you have a confirmed PE class E1 or E2, consider rapid activation of the PERT team and thrombectomy. Evaluate the patient's hemodynamic status, and depending on that, use your device of choice. In our clinical practice, on every single patient that gets a thrombectomy, we do a right heart cath first. I think that's important to document the pulmonary artery pressures when you start. Also determine the cardiac output and cardiac index. As it was mentioned, normotensive shock is very common in these patients and often missed. There's two scenarios where I would caution you to use these devices. One is in patients who have severe systemic pulmonary hypertension. You should consider deferring thrombectomy. That's a very high-risk patient that has associated with high mortality. In patients with profound cardiogenic shock, you may want to consider putting them on ECMO to facilitate thrombectomy. So with that, thank you very much. And the future for PE is very bright, and I'm looking forward to the discussion. Thank you.
Wow. Fantastic. Really great. Lots to cover in a short period of time. And I think that we have a lot of questions with regard to which device in whom, but which I think you went over. Certainly one of the questions was, when would you explicitly not offer large bore mechanical thrombectomy? I think you discussed those with distal emboli, and that's what you talked about already. But I'm wondering more about plaque, not plaque, but clot morphology? Is there a reason that you choose one versus the other based on clot morphology on CT? That's a really good question that just came up that I think would require a good answer for.
The assumption is when we're doing these procedures is that the clot is always acute, and sometimes we go in there and we realize that it's actually not acute, it's subacute or even chronic. And the only way you find that out if it's not clearly visible on the imaging studies is that when you engage the clot does not come out. These devices are very powerful, and I don't think we're smart enough to understand the timing, the acuity of these clots. It really depends on the clinical presentation. I think there's still a lot for us to learn. My personal opinion is less is more in these patients. I really do take a lot of proximal thrombus. I don't chase thrombus beyond the main pulmonary arteries. I don't know if that's the right thing to do, but there's a lot of cosmetics that is done with these pulmonary angiograms, which I don't know if they add clinical utility or value. So I think the hemodynamics at the beginning is critically important, and the hemodynamic response to thrombectomy is critically important. And those are the thresholds of when I decide enough is enough. If I get a good hemodynamic response and I remove a lot of the proximal thrombus, that's when I'll complete the procedure.
So I'll ask this question from Sahil because I think it's a pretty good question. What advice do you give a patient with a PE, with a massive large clot in the RV, lands in a center that doesn't have any interventional thrombectomy? What do you do?
Well, we can talk about it a little bit in the context of some of the most recent data, but I think that we all probably will agree, and I'll talk about it in my talk, that therapy with an interventional approach is likely better than anticoagulation alone. And we're finally accumulating that data. And if thrombectomy is not available, catheter-directed thrombolysis, as has been shown in HI-PEITHO, is effective and is relatively easy to scale. And so I think that in the minimum, that should be part of every hospital's PERT algorithm. Invasive therapy doesn't necessarily mean large bore thrombectomy. There's a host of intermediate opportunities for therapy, but there needs to be, first, as Amir pointed out, a hemodynamic assessment. That's critically important in our risk stratification. And then secondarily, there's got to be the ability to manage the patient admission, as these patients often evolve. Some will improve with anticoagulants alone. Others will deteriorate, and the ability to catch them before they fall apart is really, really important, often in a critical care setting where people are trained to look for those signs.
Yeah, and I think this is a critical question that, they're not completely finished with all of, if you don't have thrombectomy, there's still thrombolysis. The PICO data is really clear, but often you worry about a little bit of with thrombolysis, although the data looked great with high PICO with regard to bleeding, and bleeding complications, et cetera. Nick, did you want to have a comment before we go to Sahil's presentation? I feel like you want to say something.
Yeah, so we have a couple of good randomized controlled trials now, but I think we are missing a little bit the point as trialists, because we are comparing pulmonary thrombectomy with ACOS, and we are comparing ACOS with anticoagulation. But what we're missing is that these technologies probably are very complementary. And I think this is what Sahil is already alluding to. You can do an ACOS procedure first and then transfer the patient to a center that offers these pulmonary thrombectomy procedures. And at the same time, Amir was already telling, sometimes you're trying to tackle these patients with pulmonary thrombectomy, but you only encounter thrombus that is organized because it was there for like more than 2 weeks. And we discussed this also during the recorded case session, that there's also something as do your pulmonary thrombectomy first, and then if you have remaining thrombus, do an ACOS to take care of the organized thrombus.
So this combination treatments, I think, is tremendous, and the field is evolving before our eyes. And I think this is a very, very important point. So Sahil, now it's up to you. We're coming to the question that sits at the heart of this entire session. Is intermediate risk pulmonary embolism a target for thrombectomy? Why yes, or maybe why not? Sahil.
Thank you so much. Well, I'm going to try to take an approach that I think allows us to bring everybody under the tent. So I think we're all sort of dancing around the point that these patients are in a RV death spiral. This is a disease of the right ventricle, and the patients who have high risk and high mortality outcomes usually have a devolution of the right ventricle. And that's why you see these very high mortality numbers that were alluded to earlier. But just to put it in perspective, those patients with the previously called massive or cardiogenic shock associated with pulmonary embolism have very high mortality rates. But those with the intermediate risk pulmonary emboli are also at very high risk for mortality within the first 30 days. And so our sort of theoretical construct is that we want to pull people back off of the cliff from devolving into shock and bring them back on this curve so that we let the RV recover as we've seen in other states. Now, you've heard already that there's a panoply of tools that are available for treatment. In the United States, we have now a number of FDA-approved technologies ranging from large bore thrombectomy, say 24 to 25 French devices, to so-called medium bore devices, including the Indigo 16 French platform, to the various catheter-directed thrombolytic techniques, the most studied of which is the ECOS device. So I'm just going to take you a little bit on a journey as we talk about this. We can, I think, agree that high intermediate risk PE patients are at risk for hemodynamic collapse from RV failure predominantly. Catheter-directed thrombectomies, you've already seen, and thrombolysis, as I'll show you, are designed that pull that RV back from the brink. And the acute studies demonstrate that they do that. Longer term studies show that anticoagulation alone will also eventually get the RV back into shape in the main. But there are a handful of patients who will have sort of dreaded chronic complications that include chronic thromboembolic pulmonary hypertension or CTEPH or dyspnea or CTED. And obviously we haven't cracked the mortality problem. So let's just quickly go through the data. You heard about STORM. This is a trial presented by Rob Luxstein at TCT last year and published in Circulation simultaneously. This is with the Indigo catheter. It was a randomized trial comparing Indigo thrombectomy versus anticoagulation. And you can show that with aspiration thrombectomy with the Indigo system, you compared to anticoagulation alone, reduce the RV to LV ratio more rapidly, closer to normal. And this is the primary endpoint of the trial, demonstrating that there's an effect. Longer-term data have suggested that there's improved walking performance and that there's perhaps a signal for better long-term outcomes. In terms of randomization, as we heard from Nick earlier about large bore thrombectomy to catheter-directed thrombolysis, Peerless was a data set presented the year prior at TCT, comparing FlowTriever against all different kinds of catheter-directed thrombectomy and using a hierarchical win ratio approach. What was demonstrated was using the 4-component win ratio, which I'll show you more here, that in terms of the sort of therapeutic effect, catheter-directed thrombectomy with the FlowTriever system improved patients both more rapidly and reduced their risk of deterioration and their need for ICU admission. But truthfully, both therapeutic options worked well in this population. The thing that I think is provocative and really important is that we were able to show fewer patients that deteriorated in that immediate post-procedural period. And those of us that take care of these patients, that's the time when we're actually clenching our fists the most, hoping that patients survive the immediate aftermath of a procedure. And then just a few weeks ago at the ACC meetings, the HI-PEITHO data presented by Stavros Konstantinidis in a very large randomized controlled trial comparing ECOS versus anticoagulation demonstrated that using catheter-directed thrombectomy, rather thrombolysis compared to anticoagulation, clearly significantly reduced the primary endpoint, which was a composite of mortality, recurrence, and decompensation in the first 7 days, that sort of critical window after initial presentation and therapy. And you can see quite a substantial reduction in the relative risk of that composite outcome. And so I think now we finally have real randomized data that allow us to weigh which therapeutic option we might use in a patient, getting to some of the questions we've been talking about. Yes, you need lytics for catheter-directed thrombolytic therapy with ECOS, but it's very quick and easy to do. It comes with an obligate ICU stay in most places. Thrombectomy is really effective, but as Amir pointed out, it takes a little bit of a learning curve. It requires experienced hands, and it requires hemodynamic assessment before. I can't reiterate enough his point about patients with near systemic pulmonary hypertension. Those patients do poorly when they get large catheter thrombectomy. And so I would argue that in intermediate risk pulmonary embolism, it is a catheter-based therapy target, but it's a target for both CDT and mechanical thrombectomy. And it really depends on the individual patient, which therapeutic option you pull out first. I think that thrombectomy in the pro category makes the RV better faster, and it often will avoid an ICU stay. It may avoid decompensation, as Peerless 1 told us. And that technology, as you've already seen, is evolving in front of our eyes and continues to get better and better with each new device. The con is that catheter-directed thrombectomy is really the best strategy for patients who are not in centers where they have access to big catheter bore thrombectomy, or where they may not have ECMO backup. The bleeding risks in large clinical data sets have been relatively similar, which is, I think, counterintuitive. And it's just been around for longer, so there's more people with experience with these technologies. So I think the time in the field is ripe for patients to be treated with catheter-based thrombectomy or thrombolysis, and it really is dictated on individual patient characteristics and centers' experience with each technology. Thanks very much.
Wow. Fantastic. What a beautiful talk. You really put it all together for us. So a bunch of questions have come up, but just to putting it together, I think what I'm hearing is that times are changing of how we would be evaluating pulmonary embolism. There is risk stratification, there's identification of the clot, understanding the patient's status, and then incorporating a combination of therapies or certain therapies that might work extremely well. One of the big questions that I think many are asking is, how should we interpret some of these trials? The trials that are coming up. I mean, to me, I feel like they have pretty good endpoints. One of the questions is RVLV normalization, let's say, a common trial endpoint? Does it even predict anything? And I think this is a really good question. And maybe I'll go to you, Sahil, and then to Alex in terms of what you think about the current endpoints. Are you convinced with the trials that you are seeing that the endpoints are the right endpoints and that we really are moving towards the right direction? Sahil, you want to go
Roxana,
first, then I'll go to Alex.
RV-LV ratio. Sure, RV-LV ratio is a figment of the early clinical trials. I think it was used as a metric for acute success and has been a little bit of a historical remnant of those early trials. It's used almost to game the clinical trial results. I think what's important, however, is that it is a predictive of acute decompensation in the main. So I think we all feel better when we see improvement of the RV, because, as I sort of pointed out, we're trying to pull that RV off the cliff and bring it back from the brink. I think what's important to patients, however, is the long-term outcomes, and we're only now scratching the surface. We're seeing 6-minute walk test data. We're seeing cardiopulmonary exercise testing being incorporated into clinical trials. We're seeing quality of life metrics and patient-reported outcomes. And those are becoming more part of the clinical trial schema for the future trials that are coming in the next year or two. We have Peerless 2. We also have PE Track, which is an NIH-sponsored trial. That's a 3-arm trial. And there will be others with the newer devices. And I think those will get to some of these answers that people are yearning for.
Yeah, I think one of the biggest things is that now that we have all of these technologies in front of us, how do we make a decision between thrombolysis versus thrombectomy? And is that like something that, you know, is this something you decide up front, or is it how the clot is behaving that you would make a decision during the procedure? So why don't I ask this from Amir, and then Nick, maybe you can comment, and then Alex.
Yeah. So, you alluded to earlier, Roxana, who's doing these cases at a part of STEMI call. And it is, at least I could tell you what's happening in Michigan. If I'm on STEMI call, I'm on PE call. And the problem is that there's become a turf battle, which ultimately we will win. At one of the hospitals I go to, it's 1 week interventional cardiology, 1 week vascular surgery, 1 week radiology. And the problem I have with that is that if you paid attention to Sahil, the problem with this pathology, people don't die from hypoxia like we thought when we were young medical students. They die from RV failure and shock. And the best place to make that diagnosis is in the cath lab. Furthermore, when these patients have hemodynamic collapse in the cath lab, that's the best place to be where we can save them. We have devices, we have ECMO, and so on and so forth. Doing this, at least high-risk patients in the interventional radiology suite is not appropriate. Vascular surgery is doing it is not appropriate. That's in my opinion. And furthermore, they're not doing hemodynamic assessments before and after if you're not a cardiologist. And if they are doing it, I don't know if they know how to interpret it. So I think that's an important point to make. The hemodynamics, at least in my practice, guides the treatment for these patients. If it's large saddle proximal and the patient has normal tensive shock or evidence of end organ failure, such as the lactate, the creatinine going up, etc., they were very aggressive. In the absence of that, we treat them kind of conservatively. So that's our algorithm, and I think that's consistent with the recent guidelines that were recently published. So,
Yeah,
Alex, anything to add there, or Nicolas? Nicolas, go ahead.
Alex, no, Alex first. Alex first.
Yeah. Okay, thanks. In our center, we have an algorithm for that because that we also evaluate some echocardiographic signs, and these patients which are really in very severe condition. I mean, they have elevated lactates and very low TAPSI, for example. These are candidates for mechanical thrombectomy because they are at risk of very high mortality. The patients which are also at risk, intermediate high, but not so sick, we take for CDT because we think they have time, 3-4 hours for unloading of right ventricle. If we have really sick patient, we prefer performing mechanical thrombectomy. And of course, cath lab is the very important place because of this possibility of using ECMO in some patients.
So
Nicolas?
Roxana, I want to add to that. So maybe there is also a need for a reality check, and maybe you are one of the persons to give us that reality check. Because if you look at Peerless and you look at HiPITO, then you can make the argument, yes, but these were not hard clinical endpoints that made a difference, right? It was only de-escalations, but there was no difference in mortality. So in your opinion, is that enough to change the guidelines? That's one question. And the second one is, why are we not doing a randomized study, a high-risk patients, so the patients at high risk with thrombectomy versus thrombolytics?
Really good question. I mean, obviously, everybody would love to have a much harder endpoint for any of the clinical trials, and that's what we always look for in our guidelines. But we also have to be realistic. These are really, really difficult conditions. First of all, if they come in with a massive PE, it's really hard to randomize these patients and to get them into a clinical trial. We have to congratulate the people who actually got us to where we are. If you can imagine, just a few years ago, we had no evidence for any of this. And I really give a lot of credit to Kenny Rosenfield for the PERT team and all of the work that this collective group here on this panel have done to really promote this arena of patients coming in with pulmonary embolism. It's a very, very difficult scenario to do clinical trials in, even probably more difficult than STEMI patients. These patients could get sick at the drop of a dime, and I think it's very difficult to do. So in my mind, I'm feeling good that we're making some progress. Am I 100% excited about one versus the other? I wish there was more. I know that if we continue to collect more data, we will learn more. That's why I think that registries are so important. Real world data are going to be really important for us to understand the patterns of care, the outcomes with the different things, and understanding that they're apples and oranges, and you can't combine everything. But at the very least, we learn so much through our registries and setting up some metrics there. But I think the field is proliferating, and I'm excited about what is coming in the future. There will be a time where we will have definitive data. I'm certain of it. I think we're going to get to these patients faster, and we're going to be easier and earlier diagnosis of these patients, and hopefully some more preventive measures to prevent the very large saddle emboli. I think those are the most difficult and devastating conditions. I know people who died from that, and it is a really extremely devastating because it could happen to a very young patient, not just old and full of disease and other comorbidities. So I think we have a lot to work on, and I think we're moving in the right direction.
Great.
We're about 5 minutes after the hour. I don't know if there are so many amazing questions here. Honestly, I love this audience. This is a hot topic, guys. This is the hottest topic. I think we're adding to our load in caring for these acutely ill patients. I think that one of the big questions is, what's the driver of thrombectomy? To me, it's saving lives. To me, it's improving and seeing some patients turn around and not end up on ECMO, less use of an ECMO. To me, it's changing from a very high risk to an intermediate risk that could then be treated with anticoagulation. It shouldn't be about reimbursement. And that's the part that really upsets me when people ask those questions. But the bottom line is it does end up being that, right? The bottom line for pretty much everyone. But I think the future is extremely strong in this arena. And I really give it back to you all who are working in this particular area. I can't believe you're adding to your STEMI call, PERT call. God bless you, Amir. You're always looking for more work. But I also believe that we have a workforce that's exhausted, and now acute stroke, acute PE, acute STEMI, give it all to the cardiologist. Let's train more people to do this, and let's divide up the work. I don't know what closing statements maybe you want to have, Nicolas, because I need to sign off, but I'm handing it back to you, Nicolas, as the leader of this amazing, amazing day of online teaching. Thank you for having
very much, Roxana. I think you summarized it very well, and I would like to thank Alex, Amir, and Sahil for their very valuable insights and input to the 2026 Global TIO meeting. Thank you very much, Roxana, for sharing. And with this, TIO comes to a close. So thank you very much for being with us. And within a couple of seconds, I will do a final wrap up. Thank you.